I'm Michael Harrison, and this video follows on from the previous video, Eddi 2. We are going to be talking today about another way of confirming hypovolemia. Eddi is software that can detect early signs in physiological data that allows it to suggest diagnoses of adverse events during anesthesia. When making a diagnosis, it is always good to have an abundance of evidence, preferably arising in different ways. The confirmatory evidence for hypovolemia comes in the form of RAPPV, that is, respiratory associated pulse pressure volume, commonly abbreviated to PPV. During controlled respiration, the patient being on a ventilator, common during anesthesia, the blood pressure would change during each respiratory cycle. If the patient is dehydrated or low on blood volume, the decrease in blood pressure is larger. The pulse pressure, PP on the figure, is the difference between the systolic and diastolic pressure, and that changes similarly. To measure a clinically useful change, pulse pressure, it is necessary to know the mode of ventilation. Is the patient breathing spontaneously, or are the lungs being inflated? And it is necessary to know that the arterial pressure measurement is made from a good, clean pressure transducer. That is, that the arterial trace is not damped. To determine the mode of ventilation, a neural net was used, and rules were generated from this. There were two sets of rules. One was used to determine spontaneous ventilation, the other to determine IPPV, that's intermittent positive pressure ventilation. If the test for spontaneous ventilation was negative and the test for IPPV was positive, then one could assume that the patient's lungs were being ventilated. If the test for spontaneous ventilation was positive and the test for IPPV negative, then spontaneous ventilation was assumed. PPV was then not reported. If the two tests disagreed, then the algorithm assumed uncertainty and did not report the PPV. The second condition for reporting the pulse pressure variation was the validity of the arterial trace. Damping can have several causes, but kinking of the arterial cannula, or tubing, or a blood clot are the most likely. The figure on the screen is a good example. The damping was detected in this way. Mean arterial pressure to pulse pressure ratio is measured, and how this ratio trends. At a certain point, an alert would be reported. RAPPV, the magnitude of the respiratory associated pulse pressure ventilation, is reported when the two conditions are met. Here is the algorithm for measuring the PPV, which is reported as a percentage. PPV assessment is now available on many monitors. Much work has been done studying the clinical usefulness of the PPV, and a figure greater than 13% has been shown to be indicative of hypovolemia. A PPV greater than 13% and a suggested diagnosis of hypovolemia using the runs analysis system, as described previously, changes the statement of possible hypovolemia to probable hypovolemia. Context is everything. and the anaesthetist needs to take this advisory statement in combination with all other factors. For example, the onset of an epidural block with its accompanying vasodilation may trigger a hypovolemia alert. By using pathophysiological reasoning, 5-minute median value windows, and odds calculation, it is possible to suggest a diagnosis for hypovolemia. Together with a high PPV, the diagnosis can be strengthened. However, the anaesthetist is the final arbiter